Hello. So I will talk about cardiopulmonary bypass. Now, cardiopulmonary bypass, the basics we will talk about, in which we will discuss the designing of CPB machine, what are the important things that we need to take care when the patient is pre-bypass, during bypass and the post-bypass, the most important factors. We will not go very much in detail, just the basics. So, coming on the historical aspect, the first CPB was done by Dr. John Gibbon Jr. in 1953, May 6th. So, this was the first time a CPB was conducted. Okay, cardiopulmonary bypass was conducted. So, why cardiopulmonary bypass? Why do we need a cardiopulmonary bypass? So, the requirement of cardiopulmonary bypass is because a lot of heart surgeries are done. I mean, there are a lot of heart surgeries which is being required to be done, like mitral valve replacement or let's say aortic valve replacement. And during these cardiac surgery, the chambers of the heart is open. So when the chambers of the heart is open, the heart would not do its normal function. And we all know that if the heart will stop pumping, then the perfusion of other organs will get immediately affected, and simply the death of the other organs will happen. So to prevent that from happening, the patient is taken on a bypass system, right? Two important organs are bypassed, right, in this, heart and lung. So heart has to be stopped if the cardiac chambers are to be opened. So the function of heart is taken over by cardiopulmonary bypass machine, and it takes the function of two organs, the lung and the heart. And not only this, this machine also helps in controlling the core temperature of the patient, that is decreasing the core temperature, which has the protective mechanism of organ protection during these surgeries. So during CPB, the temperature of body can be regulated. We can cool or heat by heat exchanger, right? So let us discuss what are the important parts of CPB. So CPB comprises of some tubings, some cannulas, and a very important part called oxygenator. So tubing, pumps and oxygenator. Now tubing and pump, the cannulas, we have to put two important cannula. The arterial cannulation has to be done. Arterial cannulation will take the oxygenated blood to the let's say to all the organs, and venous cannula, which would remove the blood from the heart. Okay, so aortic and the venous cannulation, and there are a lot of tubings which will connect these cannula, and some important pumps which we will discuss about. So in heart lung machine, the work of heart is taken over by pump. We'll talk. During CPB, we need to have 4 important pump minimum. And the function of lung is taken over by the oxygenator. Okay. So both function of heart and lung is taken over. And that's why CPB is also called heart lung machine. So let us see the design of CPB. So this is our basic design of CPB. I have even simplified this design. So as you can see in this, the non-oxygenated blood from heart coming out from the patient goes into a collector, and from that it will go into the oxygenator. So passively the venous blood goes into a reservoir, and from that reservoir it will pass through the oxygenator. Okay, and through the main pump, right, through the main pump it goes into the oxygenator, and then from that oxygenator the blood will go to from the let's say arterial pump to the back into the heart. Okay, now there are various other pumps also, like we have a suction pump, we have a vent pump, we have a cardioplegic pump. So I'll talk about all these pumps. So I have just simplified this, let's say, design of the CPB. So as I told you, the deoxygenated blood is collected in a reservoir, then it is the oxygenator exchange, take away the carbon dioxide, and give oxygen, and that blood is returned to heart, right, through the aortic cannula. So through venous cannula, the blood is collected, and through the aortic cannula, it goes back to the body. Okay. Okay, so let us just simplify this design. So I have just simplified this design for a better understanding. So as I said, there would be a venous cannula. There would be a venous cannula. What is the site of the venous cannula? I would discuss with you. So there would be a venous cannula which would take the blood passively. So this takes the blood, collects the blood passively into this reservoir, and from the reservoir through the main arterial pump, it goes into this oxygenator, right? It goes into this oxygenator and heat exchanger, and from oxygenator, the oxygenated blood, this red tubing, right, through into which we will add the cardioplegic solution as well, goes back into the body. It will go back into the body. And there are so many other important pumps apart from the main arterial pump, right, which take the blood into the oxygenator. Is the suction pump, is the LV vent, and there is something called root vent pump as well. So I will talk about these different pumps, right. So first we have to put the cannula, right, the cannula which is connected to the tubing, which in turn is connected to the pump. So two important cannula, aortic or arterial cannula. Now, aortic cannulation is always done prior to venous cannulation. Why do we need to do the aortic cannulation prior to venous cannulation? Because if during venous cannulation the blood loss happens, right, it would be collected, it would be sucked by the pump, and it would be returned to the reservoir, right, once the aortic cannulation has been done. So in that way, that blood will not be lost. Where is aortic cannulation done? It is done in distal ascending aorta. So distal ascending aorta is the site where the aortic cannulation is done. Now coming on venous cannulation, we have two ways. So two approaches of venous cannulation. So what does venous cannulation do? Venous blood from the blood has to reach the CPP machine. Passively, this venous cannulation drains the blood from body into a reservoir. Two approaches, as I said. The first approach, we put the cannula in right atrium directly, or the second approach in superior vena cava and inferior vena cava. The two cannulas are put. So this right atrial cannulation, it is not done when the surgery is on the right side of the heart, right? And also during mitral valve replacement, the right atrium cannulation is avoided because heart is rotated and it is difficult to maintain the patency of the cannulation. So in all those cases, superior and inferior vena cava cannulation is done. So as I said, right atrial cannulation is done, but it is avoided in right side heart surgery, right side heart surgery, and also in mitral valve replacement, okay, because heart is rotated, turned in mitral valve replacement, right? Okay, so venous cannulation is done. Now then there are lot of suckers apart from these two cannulation which is connected to tubings. There are suckers which would collect the blood. So during the surgery, a lot of blood is there in the surgical field which would obscure the view of the surgeon also, and that blood could get lost also, and that blood which is in the surgical field is potassium rich blood, that is the potassium rich blood, and it is like heparinized potassium rich blood which can be returned to reservoir, and it can again be oxygenated and returned to the body. So there are cardiotomy sucker. So cardiotomy sucker prevents the loss of blood in the surgical field. These bloods are heparinized. They are sucked actively into the venous reservoir and after oxygenation return to the body. So I would show you the cardiotomy sucker. So you can see now this is the suction pump, the sucker. which this is connected to this suction pump. Okay, so the surgeon will suck the blood, right, from the surgical field. This will return through this suction pump into this reservoir. Okay, so it is returned to this reservoir. Now from reservoir it will go into the oxygenator, it will get oxygenated. So if I show you in the simpler diagram, so this is the suction pump. Now this sucks the blood and this blood returns to the reservoir. Okay, this prevents the loss of blood from the surgical field. This blood is heparinized potassium rich blood, which can be reused after oxygenation. Okay, then there is something called LV vent. So even if the heart chambers are empty, but in left, let's say left atrium, what happens, through the bronchial circulation the blood is returned. So this LV vent collects the blood from the left atrium and through a let's say a vent put in the let's say left, this LV vent put in the left atrium, this is getting sucked and again this will get returned to the reservoir. So even though heart is arrested completely, some blood continues to come in left atrium from the bronchial circulation. So this would obscure the surgical field. This is actively sucked in venous reservoir through a pump put in left atrium through pulmonary veins. So a pump is put in left atrium. So I'll show that LV vent as well. So this is LV vent. Here a pump is put through pulmonary veins in the left ventricle. This actively sucks the blood into this LV vent and through this LV vent again it is returned to the reservoir. So again this would return to reservoir. Okay, so this is very important, LV vent. So we talked about cardiotomy sucker, LV vent. We talked about the venous cannulation and the arterial cannulation. Now let us talk about some important pumps. I mean, I showed you in the image, these are the pumps which will make the blood move from one place to another. Normally in the body, heart does it. Here, the function of the heart is taken over by the pump. So minimum four important pump is required during CPB. So 4 pumps are required to conduct CPB. The pumps are of 2 types. There are roller pumps and centrifugal pump. The roller pump is more commonly seen with CPB machine and centrifugal pump is more commonly seen in let's say not in it is more commonly seen not in CPB machine, it is more commonly seen in ECMO machine. ECMO machine, okay, which is also a type of cardiopulmonary bypass. Okay, so pump 1, the most important pump, the main pump we call it. It takes the blood from the venous reservoir and drives it through the membrane oxygenator and heat exchange complex. So this is the pump 1. This pump takes the blood from the reservoir and make it reach the membrane, the oxygenator and the heat exchanger. Then the pump 2. Pump 2, it sucks the blood from the pericardial well, the surgical field and all. So pump 2 would suck the blood from the pericardial well, the suction pump. Then we have the pump 3, which sucks the blood from LV vent, which we talked about. And pump 4 is the cardioplegic pump, which gives cold cardioplegia to arrested heart and gives oxygenated blood from the oxygenator to the aortic root. So it gives oxygenated blood from oxygenator and potassium rich fluid to the aortic root. So this is the our 4th pump. So we have LV vent pump, we have arterial pump, we have the main pump which take the reservoir blood from the reservoir and make it reach the oxygenator, and we have the suction, the pericardial well suction pump. So these are the different important pumps. There could be more pumps also, but the 4 pump is minimum which is required, which I just talked about. That pump 1, which takes the blood from the venous reservoir, drives it to membrane oxygenator and heat exchange complex. Pump 2, which sucks the blood from pericardial well. Pump 3, which sucks the blood from LV vent, and pump 4 or the cardioplegic pump. Okay. Now, so this is the basic design of CPB machine. So As I discussed, it depends upon pump, the membrane oxygenator, and the tubings which is connected to each other. Okay. Now, during CPB, what is the most important thing that we have to see? What is the most important monitoring we have to do during cardiopulmonary bypass? We have to see that pump flow is adequate or not. Pump is doing the work of heart. So flow of pump has to be adequate, then only the blood, oxygenated blood would reach the body. So the flow are set at 2.4 to 2.2 to 2.4 liter per minute per meter square in a normothermic patient to provide adequate blood flow for optimal perfusion of brain and other end organs. So we need a 2.2 to 2.4 liter per minute per meter square of the pump flow, right? Pump flow for adequate organ perfusion. If there is any problem, obstruction in the pump flow, we have to check. We have to check the connection, we have to check the cannulation, everything. So this is a minimum pump flow which we require. Then arterial blood pressure. Now the perfusion has to be maintained, heart is stopped in diastole. So definitely the patient, there would be a pulse, patient would not have pulse. So mean arterial pressure target during this is, if is acceptable, between 50 to 80 mm of Hg. It should be generally targeted between 50 to 80 mm of Hg. We keep it more than 65 mm of Hg in normal patient. In patient with cerebrovascular disease, we keep it little higher. Okay, so the range is, we have to keep it between 50 to 80 mm of Hg. So these are the two important things: pump flow and the arterial blood pressure, which we need to specifically monitor during the CPB. There are other things also we monitor. I'll talk about it. Now, how do we go on cardiopulmonary bypass? How we take our patient on CPB? The first thing which is done, the heparinization of the blood. The dose is 300 to 400 unit per kg. We give the heparin 300 to 400 unit per kg body weight with a target ACT more than 480 seconds. So ACT ACT target is more than 480 seconds. So this is what target we have to achieve. Then aortic cannulation is done. Aortic cannulation, after aortic cannulation, venous cannulation is done. Why venous cannulation is done after aortic cannulation? That if during venous cannulation, if blood loss happens, then it would be sucked, right? It can be sucked into the system. Then patient goes on CPB, and then aortic cross clamping is done to separate systemic and the coronary circulation. Now, aortic cross clamping is done between the aortic cannula which we have put and the aortic root. Why? As I said, to separate the coronary circulation from the systemic circulation, because we know the coronaries originate from the aortic root. So, aortic cross clamping is done between aortic cannula and aortic root. The purpose is to separate systemic circulation from coronary circulation. Now, as I said, coronary originates from aortic root. So, after applying the aortic cross clamp, a cardioplegic solution is injected into the aortic root. This high potassium containing solution stops the heart in diastole. This potassium rich solution will arrest the heart in diastole. So, heart is arrested in diastole. Okay. Okay. So, when after putting the patient on CPB, when do we stop the ventilation, the mechanical ventilation which we are doing of the patient? Well, if there is no blood in the heart and it is not, let us, going into from heart into the lung, then there is no point of continuing with mechanical ventilation. But for that, we need to see whether the flow, the pump is doing its job properly or not, sucking and completely taking the blood away from the heart chamber or not. So, if adequate pump flow is achieved, if the CPB is in full flow, 2.6 liter per minute per meter square, then almost no blood goes into the lung. So at this point of time, we stop the ventilation. So gradually we stop the ventilation completely. Studies have shown that if we can continue the ventilation, but it would not do any benefit. And studies have shown that that it is inferior to stopping the ventilation. Continuing the ventilation has shown an inferior result compared to stopping the ventilation. So ventilation should be stopped during CPB, cardiopulmonary bypass. But when it should be stopped? When the full flow has been achieved. Now, full flow has been achieved, almost no blood will go into the lungs. Okay. Now, what are the pre-CPB checklist? Heparinization should be adequate. So, adequate anticoagulation with ACT target more than 480 seconds. We should ensure the cannula are placed properly. All monitoring gadgets are working well prior to going on CPB. All the monitors, etc., properly attached. If the PA catheter or Swan-Ganz catheter is placed, now we little pull it out for 4 centimeter. 4 centimeter it is pulled. And T probe, transesophageal echocardiography probe, is kept as a standby. It is kept as a standby in case of let's say in emergency and when we need to diagnose any problem of the heart. So it should be kept probe in standby. Okay, on CPB, when the patient is on CPB. Now during the patient is on CPB, again we have to ensure adequate anticoagulation is there. The target ACT is more than 480, right? So target ACT is more than 480 seconds. And every half an hour, every 30 minutes, the ACT is the activate. What is the full form of ACT? I presume all of you know. That is activated whole blood clotting time. Activated whole blood clotting time. So this is repeated every 30 minutes to maintain the targeted value throughout the CPB. So targeted value is what is very important to keep in mind. It should be more than 480 seconds. Okay. Blood pressure should be checked. Blood pressure, it is non-pulsatile with MAC between 50 to 80. So heart is not pumping. Patient is on CPB machine, so it's non-pulsatile flow with mean arterial pressure target between 50 to 80. CVP, the central venous pressure, should be between 0 to 5 mm of Hg. If it is elevated, there would be some problem. The venous blood is not getting drained out of the right atrium properly. We need to check for the venous cannula. That is it working properly? Is the patency is proper or not? So CVP should be between 0 to 5 mm of Hg, not more than that. ABG should be adequately checked at a regular interval to see for the oxygenation, to see for the CO2 value, to see for the pH, to see for other electrolyte and hematocrits. So it should be checked for oxygenation, for hematocrit, CO2 removal and electrolytes. Again, like ACT, which is repeated every 30 minutes, ABG is also repeated every 30 minutes. So we repeat it every 30 minutes, okay, as a point of care testing. And the arterial PO2, which again I will discuss, the parameter target is between 150 to 250 mm of Hg during CPB, okay. Now during CPB, we should always see the urine output of the patient and document whether urine output is there or not. Because one of the most common organ getting affected post CPB is kidney, and we have to ensure the adequate perfusion of kidney is there or not. And this is also indicated if the urine output is not good, that adequate perfusion is there or not. So we need to document the urine coming from CPB to ensure the adequate organ perfusion. Maintenance of renal blood flow is achieved by maintaining adequate CPB pump flow throughout the CPB to minimize the risk of AKI. The risk of AKI is very high post CPB. The chances of kidney dysfunction is very high post CPB. And to minimize it, we have to keep the adequate pump flow. You know, so many times the cardiac surgeon, the CTVS surgeon will keep on asking, what is the pump flow? What is the pump flow? They're also concerned the pump flow should be adequate to maintain the perfusion of the body. And we should also regularly check the pump flow. Okay. Now, during the CPB, during the procedure, how do we maintain the anesthesia? Well, definitely, we need to give our anesthetic agents. How do we give it? It is given through the CPB machine. Through the CPB machine, where we have a, let's say, our device, a vaporizer attached to the CPB machine to give inhalational anesthetic agent, right? It is mostly administered through CPB circuit. We can also add IV anesthetic agent infusion, right? We can also add IV anesthetic uh, agent infusion. We have to maintain the adequate depth of anesthesia. BIS monitoring during monitoring would be very helpful. So we have to maintain the adequate depth. So maintain adequate depth. Okay. Now, number of studies have shown that if adequate depth with anesthetic agent is not maintained during CPB procedures, then post patient has a lot of incidents of recall and awareness and led to post-traumatic stress disorder. So we need to maintain the adequate depth. So if possible, attach the BIS monitoring. Now, neuromuscular blockade employed through CPB, again it is added to the blood through the CPB machine to facilitate the surgical operating condition. So as we maintain the anesthesia during any normal procedure, here also we have to maintain it, but we have to put our drugs and everything through the CPB machine because the blood is not now moving through the normal circulation. The blood has been bypassed from the body, right? And it is now moving in the CPB machine and then getting oxygenated and getting returned to the body. So in this oxygenated blood, the anesthetic agents are also added through the special device which is attached. Okay. Now, I said the CPB machine has two work. One, it maintains the oxygenation of the blood out of the body, right? It maintains the flow of the blood into the body, and other, it modulates the core temperature of the body. So, temperature, because we have oxygenator and heat exchanger, both. It acts as oxygenator and heat exchanger. Now, we can go for mild, moderate or deep hypothermia during cardiopulmonary bypass, during cardiac surgery. So, mild hypothermia, the range is between 32 to 35 degrees Celsius, moderate 28 to 32 degrees Celsius, and deep less than 28 degrees Celsius hypothermia is used as a protective strategy for brain and vital organ during CPB for many cardiac surgery. So, mild hypothermia is normally practiced during coronary artery bypass surgery, right? Why do we practice this hypothermia? As we have discussed in so many our lectures, that hypothermia is one of the best way for brain protection, for organ protection. Per 1 degree decrease in the core temperature decreases the oxygen requirement of brain by 7%. So, cerebral metabolic rate and oxygen consumption decreases by 7% per degree decrease in the core temperature. Then, mild hypothermia approximately, as I said, is 34 degrees Celsius and it is used for CABG surgeries most commonly. Then moderate hypothermia is selected for valve repair surgery, cardiac valve repair surgery due to length and complexity of these procedure. And a moderate reduction of core temperature would have its cardioprotective and neuroprotective effect. So this reduction in core temperature would confer some neuroprotective benefits, right, as the deep hypothermia gives. Now, deep hypothermia, deep hypothermia is practiced mostly for the ascending aorta repair, for the repair of portions of ascending aorta. So, in case of ascending surgery on ascending aorta and all, the deep hypothermic arrest is preferred to produce a complete isoelectricity for a brain protection, right? So, mild hypothermia is for CABG surgeries. Moderate hypothermia is normally practiced for cardiac valve repair surgery or complex surgeries, and deep hypothermia mostly for the vascular surgeries which is done on ascending aorta. Okay. Okay. What are the important parameters which we have to maintain during CPB? By point of care monitoring, like by monitoring the ACT, monitoring the AVG. What should be the target parameters? Seeing the blood pressure of the patient, the adequate ACT during CPB should be typically between 400 to 480 seconds. We try to keep it above 480 seconds. pH should be between 7.35 to 7.45. We should not allow acidosis. PCO2 35 to 45. PO2 between 150 to 250. Flow rate on the CPB machine should be 2.4 to 2.4 liter per minute per meter square. Mean arterial pressure should be more than equal to 65. The range is 50 to 80. And if a patient has any cerebrovascular disease, keep it little higher. And mixed venous oxygen saturation should be above equal to 75%. So these are the important parameters that we have to maintain during CPB. Okay. Now, during CPB, what is the HB that we have to maintain? See, we give a cardioplegic solution and that causes hemodilation. But we need to maintain a certain hematocrit. So, hemoglobin, if it is less than 7.5 gram, that is less than hematocrit 22%, the initial treatment during CPB is removal of fluid by ultrafiltration whenever possible. Okay. The requirement to transfuse the PRBC during CPB depends on that fact that if it should be individualized. Transfusion is required or not, it should be according to the procedure. If by hemo concentration we are unable to maintain the hematocrit, or even after doing all the measures we are unable to maintain the hematocrit, then only the blood transfusion has to be done. The CPB, when the patient is on CPB, hyperglycemia is one of the common thing which we see, and blood sugar should also be maintained. The blood sugar monitoring should also be done like point of care monitoring every 30 minutes. So, Society of Thoracic Surgeons and European Association for Cardiothoracic Surgery, that is EATS, they have given the guideline to maintain the blood glucose level less than 180 milligram per deciliter. So, less than 180 milligram per deciliter is the target blood sugar that we have to maintain during CPB. And we can do this with single or the intermittent doses of insulin, right? Or we can, single dose if it is effective, or continuous infusion has to be started. But we have to keep it below 180. If it is above 180 persistently, we can go for insulin infusion. Blood glucose and potassium is monitored every 30 minutes to prevent hypoglycemia and hypokalemia in response to treatments. Okay, so remember, hypoglycemia has to be prevented, hyperglycemia has to be prevented, and insulin is given through the CPB machine. Okay, hypocalcemia is again commonly seen during cardiopulmonary bypass. So, hypocalcemia, what happens in this? The ionized fraction of total calcium is decreased. This is common and we typically correct it by giving calcium chloride 5 to 10 milligram per kg IV. But timing of treating hypocalcemia is important. We should avoid administration of calcium when the aortic cross clamp is in place, or at least 10 to 15 minutes after releasing of aortic cross clamp, right? This allows the period of myocardial reperfusion. So, hypocalcemia is common, but treatment, when we have to treat it, is critical. Hyperkalemia is again very commonly seen because we give potassium-rich cardioplegic solution to keep the heart in diastolic arrest. So, transient hyperkalemia is common during CPB, particularly just after administration of high potassium cardioplegic solution. Now, if the persistent hypokalemia is there, we need to treat it with GIK. But after giving the cardioplegic solution, if there is a transient hypokalemia, we may wait, monitor further, look in the next investigation. If there is a persistent hypokalemia, then glucose insulin solution can be used. Hypokalemia can again be seen. Hypokalemia is also common. So, hypokalemia is why hypokalemia happens because of giving insulin to the patient, adrenaline to the patient, the beta adrenergic agonist. So, insulin, adrenaline administration, etc. can cause hypokalemia. And in post-bypass period, typically we see hypokalemia. So we should treat it with the potassium chloride solution through the central line, through a slow infusion. So hypokalemia has to be treated. Okay. When we have to take the patient out of the CPB, so these are the monitoring we do during CPB. When we have to take the patient out of the CPB, we have to do certain checklists. We have to check the ABG for hematocrit. It should be minimum 20%. We have to check the electrolytes. It should be within the normal range. We should ensure the patient should be adequately rewarmed above 36.5 degree. Adequate blood products in our hand. Good rhythm, right? The rhythm patient is not an arrhythmia. And volume status should be adequate. The availability of the pacemakers should be there. Number of times the patient goes into arrhythmia and bradyarrhythmia, etc. So we should have the availability of the temporary pacemaker. Inotropes should be ready. So inotrope should be ready in case we have to start the inotropes. On minimum infusion of the inotrope, the baseline we can start. And adequate de-airing should be checked for. We should check for adequate de-airing of the entire circuit. Now, this can be done through the transesophageal echocardiography. So, centers check for any remaining air through transesophageal echocardiography. So, adequate de-airing should be there. Okay. So, these are the important precautions we need to take when the patient is coming out of the CPB. Okay. So, we talked about what important monitoring we do during CPB. Right? What is the important pre-CPB checklist when the patient goes into the CPB? Then what is the sequence of events going on the for the patient going on CPB? And just before weaning the patient out of the CPB, what should be the checklist? So we have discussed the entire course of the CPB. Now, one more thing I want to discuss before finishing off is the cardioplegic solution which we use. So the cardioplegic solution which we use, the standard cardioplegic solution is hypothermic, hyperkalemic cardioplegic solution with 20 milliequivalents potassium per liter, right? In the ratio 4:1, 4 parts of blood and 1 part of crystalloid, right? So this solution, that's why there is so much hemodilution in during CPB. This is given at regular interval to maintain the cardiac arrest. So this is the cardioplegic solution, hypothermic, hyperkalemic solution. Okay. Then we have Del Nido formula also for cardioplegic solution, which is administered in ratio 1:4, 1 part of blood and 4 parts of crystalloid. So this is just opposite to the regular standard one which we are using, the De Nido formula, 1 part of blood, 4 part of crystalloid as the single dose cardioplegic solution. So this is used as a single dose cardioplegic solution. Okay. Then there are cardioplegic solution without blood also, which is also being used at some particular clinical conditions. Okay. So we have different cardioplegic solution. Mostly the cardioplegic solution is mixture of crystalloid and blood. The ratio depends upon whatever you have chosen. The crystalloid contains 20 milliequivalents potassium per liter. So these are the important things that we have to remember about cardioplegic solution. And this is all about cardiopulmonary bypass machine, which takes over the function of heart and lung during cardiac surgery. I hope you have understood. Thank you.